Good evening, everyone. Welcome to Breast Cancer Risk Assessment and Risk Reduction. Often, Breast Cancer Awareness Month is aimed at people with a diagnosis of breast cancer. However, many people are unaware that they may be at increased risk and, in fact, can take action to both assess and to decrease their risk. This evening, we are really fortunate to have four amazing speakers, all renowned in their field, who are going to give us a sampling from surgery to medical intervention to risk assessment, so we can all learn and be better informed as to our breast cancer risk and what we can do about it. Our first speaker is Dr. Julia Smith, who's the clinical director of the cancer screening program at the Laura and Isaac Perlmutter Cancer Center. Dr. Smith has been a clinical expert in the field of risk assessment for cancer with the goal of increasing surveillance, early detection, and prevention since the inception of the field, and in educating the medical community and the public around the United States as well as in other countries. Dr. Smith, we are fortunate to have you this evening and look forward to your talk.
Thank you very much, Marlene. It's a pleasure to be here, and many thanks to all the women who are joining, and if there are men as well, because this is something that's near and dear to our hearts. All of us have worked together for a long time to try to understand what makes a woman at risk or at higher risk than the average for a breast cancer, and what can we do then to identify that risk and then reduce it. So for my first slide, I wanted to point out the factors that every woman and man should consider when they're thinking about whether they have risk. So obviously, gender is important. Women tend to get breast cancer much more frequently than men, but men get breast cancer as well, so you can't ignore that. Age is important. Well, actually, as we age as women, our risk of breast cancer rises. But when you're thinking about your risk, if you have factors that give you a high risk, then early age, that's premenopausal, and we use 50 years old as a surrogate for menopause. So under 50, if you have any factors that give you an increased risk, that's very significant. Now, family history and genetics are near and dear to my heart, and they are very important. I'm not actually going to focus on that so much tonight, but I'll make a comment about it at the end. But every woman needs to talk to their family and try to understand, is there a history of cancer in your relatives? Are they on your mother's side or your father's side? What is the diagnosis? Because not just breast cancer diagnoses, but other cancer diagnoses may indicate an elevated risk for breast cancer. And what age was the diagnosis? Because of what I've just said. And then genetics should be evaluated when appropriate. Breast density has gotten a lot of attention, even in the media in recent years, and it is important. If you have extremely dense breasts, number one, it's more difficult to evaluate dense breasts on a mammogram. But number two, we know that just that extreme density can give some increased risk of breast cancer. So that's an important factor to know. I'm going to focus on this next one tonight because we don't feel that women have sort of a general good understanding, and many practitioners need help with this. The personal medical history of breast diseases, of benign and benign, actually, breast diseases. And then lifestyle and environment, very important, very important. And all I can say here is that I've been preaching this for decades, and everyone hates me when I say it, but don't drink. Try to keep the amount of alcohol you're taking to a minimum. It's a moving target. We don't have exact science on this, but I would recommend that women not drink more than 3 drinks a week. Try to exercise, try to eat healthy, a kind of Mediterranean diet, and absolutely don't smoke. And if you're smoking, find a way to quit, and we'll help you if you need it. Here's what I wanted to really focus on in this presentation. We as women go I hope all of us go regularly after the age of 40 for mammograms, screening mammograms. Now, often something pops up, and the next thing we know, we're stuck with a biopsy that gives us an abnormal tissue. So it's either going to be a benign breast tissue that's called usual ductal hyperplasia, or it's going to be benign breast tissue that is atypical. So we're looking at proliferative versus non-proliferative disease. Non-proliferative disease or usual ductal hyperplasia is not only benign, but it doesn't have any significance in terms of increasing one's risk of breast cancer. Atypical or proliferative breast disease on biopsy, atypical ductal hyperplasia, ADH, atypical lobular hyperplasia, ALH, or lobular carcinoma in situ, LCIS, which is not cancer, but all three of those do have some implications for increased risk and have to be evaluated in the individual woman, taken seriously, and a decision made about screening and prevention. So here's what we know. We have done well, and that's why we are doing so well in this country compared to many other countries, even in Europe. We've done well with screening mammogram detection of invasive breast cancer. But we also know that these screening mammograms detect benign lesions more often than they detect the invasive breast cancer. So there is a recent study by Dr. Lynn Hartman, pretty recent, where she looks at all these atypical, so these are the atypical hyperplasia lesions. These are the lesions that when you see a biopsy and you see these ADH, ALH, LCIS, those are the type that have the potential to increase one's risk of breast cancer in her lifetime. And in that study, with 12 years of follow-up, still, despite the increased risk that we know is there with those lesions, a minority of women, only 20%, developed a breast cancer. So the vast majority, even with these, and that tells us that many of these lesions, although we know they increase one's risk, many do not actually progress to an invasive breast cancer. So this study concluded, after she looked at the various numbers, and we're going to talk about the numbers because this is the kind of thing that your doctor always talks to you about when you get a diagnosis of these abnormal cells on biopsy. And what they concluded was that this kind of atypical hyperplasia confers a relative risk of 30% for subsequent diagnosis of breast cancer, 25 years of follow-up. Now, if you look at other studies, you can find that they're all over the place. This was 30%. We have other studies that show that there's only 10% or less risk with these lesions, these atypical lesions of developing breast cancer. So why this big spread? And that's very important because this is where we come to the individual patient. The big spread here could have to do with various factors about the studies and the samples. I mean, for instance, the sample size is important. If you get a lot of tissue, you may see more abnormal cells. If you followed these women for a long time, you may see more breast cancers develop. It depends on the study inclusion criteria, who they look at, what they exclude, and then very importantly, there are pathologic differences among labs. Pathologists can actually differ about what they call a cell, whether it's atypical or not. So these are really important things. How do we sort of tease this out, and how does that help women know what they should decide if they get a biopsy diagnosis of a benign lesion? Here is a critical slide, and it's something that we don't usually think about as lay people when we're sitting in a doctor's office because it's statistics, and many of us didn't really want to take statistics. And if we did, there was a lot that went over our heads. But this is one piece that's very important to understand. Absolute risk versus relative risk. What is your doctor telling you about the risk? So absolute risk means the baseline, like what is the likelihood, the chance that something will occur over a given period of time. That's absolute risk. Relative risk is when you compare two groups of people, two groups in this case of people. So the likelihood of something happening in one group compared to another group. You can see from this that obviously you can't make the determination of relative risk like Dr. Hartman did of that 30% unless you know what the baseline is, the absolute risk. But those are very, very different ways statistically of looking at risk. If we go back to the Hartman study, this was a very well-planned and detailed study. Dr. Hartman looked at over 6,000 women who had non-proliferative disease. Remember, non-proliferative means you got a biopsy, it's benign, and there are not atypical cells. It's usual ductal hyperplasia. When they looked at that, they expected out of this group of 6,061 women, the expected rate of cancer, breast cancer, would have been 297.7 women. But they found that 379 women in this group, non-proliferative, benign disease, developed breast cancer. So when you look at that, there's about almost 180 to 100 individual difference between the two. And what that translated to was a 27% increased risk of breast cancer over the following 15 years. So that's the relative risk. 27%. It sounds quite high if you're sitting in your doctor's office and they say to you, listen, you had this benign, totally benign biopsy, but it means you have a 27% relative increased risk of breast cancer in 15 years. That's a little bit frightening. If you break this down to absolute risk, which again is what I think you really have to go through if you're in this situation. So let's look at absolute risk in this study. 100 women, we know, 100 women in the general population, we know that we expect 5 of those 100 women to develop breast cancer over 15 years of follow-up. Now, with non-proliferative disease in this study, 100 women, 6 breast cancers developed over 15 years. So that gives you an absolute risk increase of 1, because there were 5 in the general population and 6 in the population who had the non-proliferative disease. 1 more woman in 100 women will develop breast cancer with that. Now, that's why I say you should look at absolute risk. So let's look at the atypical hyperplasia. Now we're talking about the kind of lesion, atypical ductal hyperplasia, atypical lobular hyperplasia, and LCIS, the kinds of lesions we said, those biopsies can absolutely increase the lifetime potential for cancer. We break down the absolute risk in that group, right? We know that all the studies published show that there's a 4 to 5-fold increased lifetime risk if you have a biopsy diagnosis of ADH or ALH. But the absolute risk we look at, again, in the general population, we know in 100 women, 5 will develop breast cancer. With atypical hyperplasia, 19 out of that 100 will develop breast cancer. So that's an increase from the non-proliferative lesions, right? We said that it was only 1 more, 6 out of 100 in the non-proliferative. In this, the atypical, it is increased. It's not 5 as the baseline. It's not 6 as the benign non-proliferative. It's 19. But what does that mean? It means that if you're sitting there and you're one of these women, then you have and out of 100 women, 81 of you will not get breast cancer. 19 will, so it's increased, but 81 will not get breast cancer. Far, far more will not get breast cancer. So how do we figure out which women sitting in front of us, and when you're that person, who are you in that group? Are you in the 19 or are you not? So there is atypia and then there's atypia. And not all atypia is the same. And that's very important. When you're sitting there trying to figure out whether you have an increased risk because of an abnormal biopsy, number one, the age is important because women who have cancer or abnormal biopsies at a young age have a higher risk. Number two, you have to have the pathologist review the actual tissue because the number of foci of atypia, remember we said that the size of the tissue sample is important. Well, that's important because if you have more foci, like 3 or more atypical foci, you have a lobular infiltration, or you have what's called TDL, that's terminal duct lobules that are greater than 2. In other words, a lot of the cells in the specimen are atypical. That is suggestive of a higher risk. And then the grade or the classification of the type of atypia, the pathologist can give you a sense of whether it looks a little more abnormal or a little less abnormal. Necrosis refers to tissue, to cell death. And then when you see cell death, it's because those cells are not often behaving normally. They don't have the normal blood supply and they die. So the amount of tissue that's affected and the kind of what the grade is important. And then there has to be what's called concordance. In other words, the radiologist and the pathologist have to agree that they got the right spot when they did the biopsy. And finally, family history is very important because that tells us something about women who would have a higher risk. I just point out on this bottom part of the slide that we have all these statistical epidemiologic breast models that we use, we plug in, but none of them are perfect. And some overestimate risk of one thing and some underestimate it. So it's important to just make sure that you find out where you fall in all of this. When you think that you fall into this group of higher risk, when you're sitting there with your doctor because you had a breast biopsy that showed atypical cells, but not cancer, and you're going through all those factors that we talked about, the age and the kind of cells, what they look like, how many abnormal cells, all of that, then you want to think about, well, if I am at higher risk, what can I do to reduce my risk? One thing is that there's what's called chemoprevention, which you are going to hear much more about. So I'm not going to expand on it now. But the word chemoprevention, there's no chemotherapy involved. This is hormonal therapy, but we use that term just historically. Well, women under 60 are a little less likely to be considering chemoprevention for a number of reasons. For one, there's the issue of fertility. It's getting to be older and older age, but certainly till the age of 50, there's the issue of fertility. And for another is that what we said is that women after the age of 60, as we age, our general risk of breast cancer rises. We also want to consider chemoprevention or hormone therapy to reduce the risk of breast cancer in women who have, by any of these statistical risk models, a high risk. And then we want to consider, remember I mentioned LCIS, lobular carcinoma in situ, that if it turns out that you have that diagnosis, you want your doctor to speak to the pathologist and try to identify whether it's what's called pleomorphic or classical LCIS. They are different diagnoses, and we actually think that at this point now that pleomorphic is much more suggestive of risk and may even approach the risk of a stage 0 breast cancer. It's not done at every institution, that pathologic distinction. So that's an important thing to know about and to make sure you ask. And then, of course, you have to discuss with your doctor, well, what are the risks of these drugs if I take them, and what are the potential benefits? I just put this last line in here again. All those alphabet letters are the main studies that were done looking at risk reduction with chemoprevention. And I just want to point out that you do reduce the risk with chemoprevention, but you don't eliminate it. Okay, so you still have a risk even with chemoprevention. And my last slide is just to point out something that I said in the beginning is near and dear to my heart. Think about what your risk is in a relative sense. We talk about risk and we talk about, well, did this person have any children and how old were they when they got their period? That's called menarche. Did they have hormone therapy? How old were they when they went through menopause? What about the breast density? What about these diagnoses of ADH and ALH? Well, I just want you to look at this slide because it's very important if you think that you have a hereditary, a familial cancer syndrome. If there are people in your family who had cancer at a young age, and that's a whole spectrum of cancers, not just breast cancer, or unusual cancers and clusterings of cancer. This, I think most people now have heard of the BRCA gene and the BRCA mutation. If you say that women, because that confers a high risk of breast cancer, a high lifetime risk. And if you say that, let's give that a value of 10, that's the highest risk single factor we can come up with. Then you can see if having a BRCA mutation is 10, you drop down to 4, a relative risk of 4 for these atypical ADH, ALH, increased breast density, a relative risk of 4. So it's less than half. It is important to know whether you have risk, to identify how much risk you have, and then to make a decision individualized with your doctor about how to follow you and whether or not to give any hormone uh, drugs to reduce the risk. So I'll stop there because we are supposed to keep our presentation short.
Thank you so much, Julie. That was really informative. And if everyone can save questions or comments till the end. Our next speaker is Dr. Mary Gemignani, who joined NYU Langone Health in May as our new chief of breast surgery. With great welcome, her research interests focus on breast cancer in young women and those with genetic predispositions, such as carriers of the BRCA mutation. Tonight, she will discuss the surgical options for women at high risk. Dr. Gemignani, we look forward to your talk. Thank you.
Thank you, Marlene. It's such a pleasure to be here this evening. So what I really want to talk about is when we talk about surgery for risk reduction, we're actually talking about our highest risk patients. So those who, as Dr. Smith was talking about, hereditary risk, so very strong family history of breast and mostly and sometimes ovarian cancer. So who should consider having surgery to reduce the risk of breast cancer? Well, individuals who are known to have inherited a mutation that greatly increases their risk. So women and even trans men who have not had top surgery. So these individuals are sort of defined as having a high risk of breast cancer, but are also uh, other types that are not always known to have inherited a harmful mutation. So like if you have multiple family members and you also have LCIS, if you've had radiation to the chest, like if you've been diagnosed with a Hodgkin's lymphoma at an early age, you're at a particularly high risk. So can surgery be used to reduce the risk of developing breast cancer? It's something that we are often asked when we have these consultations with patients. Yes. So risk-reducing surgery is also called preventive or prophylactic surgery, and it can lower the risk of breast cancer in people who are very high risk. And when we talk about this, we're really talking about our BRCA1 and 2 carriers, our P53 mutation carriers, and some other mutations like PTEN. So these are folks who have really high elevated risk. So their lifetime risk isn't the same as someone who has ADH, but sometimes even approaches 60 or 80%, depending on other family members that also have mutations and also have risk. Next slide. So how effective is risk-reducing surgery? Well, the effectiveness of risk-reducing mastectomy is now well known and well documented. So multiple societies have put out statements regarding what the protection from these types of surgery are, and particularly in women who are BRCA1 and 2 carriers. We often say that the risk reduction is 90 to 95%. which is never going to be 100% because with breast, it's hard to take 100% of the breast tissue out in all cases, but the risk reduction is really high. So I always talk to my patients about, even after these types of surgeries, to have some self-awareness of their bodies, and if anything changes or feel suspicious, to come back, even though you had a risk-reducing mastectomy. So it's always important to have a multidisciplinary, multiple folks kind of having this discussion about whether you should consider this type of surgery, and it's also important to review some of the potential side effects and complications that can occur from this procedure. So the types of risk-reducing surgery, and I'll focus on breast, but there's also, I have a slide or two on ovarian cancer risk for our highest risk bracket patients to also discuss. So types of mastectomies. Total mastectomy usually means skin sparing. You're removing the breast and the nipple, traditional mastectomy styles. Nipple sparing mastectomies, they were born out of over like now almost 2 or 3 decades of use for nipple sparings. And it comes from, like, sometimes there's dissatisfaction with the types of nipple reconstructions that can happen. And this is a more cosmetic approach. Current studies have shown that they're feasible to do and safe to do in the vast majority of cases, but patient selection is important. And reconstruction options are part of this discussion and decision making. So when we think about skin-sparing mastectomies, we're thinking about and using of tissue expanders or implant type of reconstructions, where basically you're saving all of the skin and the muscle, and there's a temporary implant that gets put in by our plastic surgeons and expanded over time. And then there's a second operation that will be an exchange of this expander. Nipple-sparing mastectomy is very popular in the prophylactic setting. There are different ways to do the incision, and sometimes we just go radially right next to the nipple, but most of the time we go inframammary. Now, it's important to know that this is not the same kind of surgery as you think of when you're augmenting your breast. This is replacing breast tissue with a reconstruction. So although sometimes the cosmetics are great, the sensations are not the same, and you do lose sensations even if the nipple is there. And there's always this discussion of the, people call these the flaps, or the transfer of tissue from your abdominal wall to make a breast. These are definitely more involved, but an option for reconstruction, especially in cases where we're not using implants. And over the last, I would probably say the last decade, there has been a lot of interest to go back to these types of flat aesthetic closures. So for some women, there's no desire to do a reconstruction, and sometimes a plastic surgeon or a breast surgeon can do these closures that are very flat and cosmetic in appearance. Next slide. So what are the potential harms of risk-reducing surgeries? So as with any other major surgery, potential for complications, bleeding, infections, psychological well-being due to the change in body image. Surgeries are irreversible. So often when I meet with someone to discuss this kind of surgery, they come back multiple times. It's not a decision that's easily made, and there's a lot of potential for regret. So folks that are very satisfied or have less regret are folks who come to their own decision on their own after having had multiple discussions about it. There's loss of sensation, like I mentioned, even when you do a nipple sparing option, and sometimes people don't realize that. So who should a person talk to when considering this type of surgery to reduce the risk of breast cancer? Well, if you have a strong family history of breast cancer, ovarian cancer, or some other cancers like Dr. White was mentioning, consideration for genetic counseling to understand whether they are truly at a very high risk, and in many cases, testing. The decision to have any surgery of this type to reduce the risk of breast cancer is major and should not be underestimated. And a person who is considering this kind of risk-reducing mastectomy should meet with a breast surgeon and a plastic surgeon to kind of understand the details and the recovery and the surgical treatment that's part of this endeavor. And sometimes you really do need to discuss your own thoughts and discuss it with a clinical psychologist or psychiatrist if needed, especially if you think that there may be some regret issues that are going to be coming from these decisions, or you're not sure about how that's going to fit in and how your own body image is going to feel. So I just wanted to have 2 slides just to add this on, because we're talking about risk reduction. So it's important to talk about bilateral salpingo-oophorectomy. And so what this means is removal of the tubes and ovaries. It is the best risk reduction that we have for our highest risk carriers, the patients who are at risk for ovarian cancer, because there's not great screening for breast. There's great screening for breast cancer detection. For ovarian cancer, not so much. And most societies look at this and say that for those folks at risk, somewhere between age 35 and 40, you have to consider your own family and your choices, and also have to review potential side effects, complications of this procedure. These are usually done by GYN oncologists, and it's important to realize infertility, menopausal symptoms, and osteoporosis that can occur from this. So hormone replacement therapy is the sudden drop in the estrogens that occur from having a bilateral sublingual oophorectomy induces early menopause. So we know that if there's no breast cancer history in a prophylactic setting, the use of hormone appears to be an option up to the age of 50, and it does not seem to decrease the protective effect of having had the ovaries removed for the vast majority of patients, according to the data that we have. So in conclusion, when you think about surgical risk reduction strategies, they're effective for our highest risk patients. It's important to consider the magnitude of risk based on the age of the person that's coming in where they're being counseled, the effectiveness of the type of surgical intervention, and the side effects associated with each type of intervention. There are certainly alternative strategies exist for even women who are at the highest risk for developing breast cancer, and the rest of our panel will cover these, but that obviously includes some high-risk screening surveillance, which includes MRIs and mammograms, and usually we stagger those for our patients so that they're getting some evaluation on a regular basis, and chemoprevention. And with that, I think I'll go ahead and turn over to my next speaker.
Thank you so much, Dr. Gemignani. That was really comprehensive and an excellent overview of options that women have. Our next speaker is Dr. Simons, and she is the breast medical oncologist at Perlmutter Cancer Center and a clinical assistant professor at the NYU Grossman School of Medicine. Her interests include cancer genetics, risk assessment and reduction, and developing individualized cancer treatment and prevention strategies for those with predisposing mutations. Dr. Simons, we look forward to your talk. Thank you.
Thanks very much, Marlene. I'm going to be talking about pharmacologic risk reduction, so what we've called chemoprevention previously in this talk. I like to take the chemoprevention out because I do think that terminology is a little bit confusing, but essentially I'm going to talk about medications that we can use to try to reduce risk in our high-risk patients. So Dr. Smith talked a little bit about this already, the high-risk breast lesions. I'm not going to focus too much on it, but just to remind you, when we talk about these lesions that are considered at putting patients at increased risk, we're talking about hyperplasia, so either atypical ductal hyperplasia, atypical lobular hyperplasia, and then LCIS, lobular carcinoma in situ. These are markers for increased risk, but not what we consider precancerous lesions. And then the studies that I'm going to talk about mainly focus on these, and there's some of the studies that also focus on DCIS, which is kind of a separate category that we treat a little bit differently because this is considered a cancer precursor or kind of a stage 0 disease. And so we manage those a little bit differently than the other high-risk lesions. So this was one of the first breast cancer prevention trials that was done, the NSABP P1 study. This was done quite a long time ago already, actually. So these patients in this study were enrolled from 1992 to 1997. They looked at about 13,000 patients. And the patients that were included in this trial were those that were over the age of 60 that didn't necessarily have other high-risk lesion or other high-risk features, I should say, or patients that were considered higher risk that were over the age of 35. So that was using this Gale risk model that Dr. Smith touched on, which includes risk factors like family history, previous biopsies with hyperplasia, or a history of LCIS. And basically, these patients were randomized to an anti-estrogen medicine called tamoxifen, which is a pill that you take once a day at 20 milligrams versus placebo for a total of 5 years. And you can see in the graph on the left, where when they looked at the incidence of breast cancer and also what we consider non-invasive cancer or DCIS, you can see that there was about a 50% risk reduction of invasive breast cancer in the tamoxifen group compared to the placebo group. Similarly, there was a reduction in the non-invasive cancer group as well. It wasn't quite as significant as we see in the breast cancer group. One interesting other finding in this study was that they looked at a subset of the patients that had BRCA mutations, so healthier BRCA patients. And what they saw was that there was also a risk reduction in the BRCA2 mutation carriers in terms of the incidence of invasive breast cancer, but they did not really see a difference in the BRCA1 mutation carriers. And that's largely because these medications are really helping to reduce the risk for estrogen receptor positive breast cancer, which is that we traditionally see more in the BRCA2 mutation carriers. So unfortunately, some of these medications have side effects. I wish that we had medicines that didn't, but for the most part, they all do have some side effects. And I think our next speaker is going to talk a little bit more about some of the ways that we manage some of these side effects. But I just wanted to point out the more serious side effects that we can see with tamoxifen therapy. It's not particularly common that we see these, but since they're more significant, it's just important to know. So the trial did see that there was a higher risk for blood clots in the tamoxifen group compared to the placebo group. Again, it's not very common that we see this, but it was higher rates in the tamoxifen group. And then in the lower graph, you can see that there was also a higher rate of uterine cancer that we see in the tamoxifen group compared to the placebo group. With both of those side effects, we tended to see the higher risk being in women over the age of 50. So again, that's kind of a surrogate marker that we use for menopausal patients. So we did see that in the patients that did develop these side effects, they tended to be a little bit older. So one other study that I just wanted to highlight was the IBIS-1 trial. This looked at similarly tamoxifen versus placebo in these higher risk patients. And it basically showed similar results to the previous trial that I mentioned. The reason why I just wanted to highlight this study was you can see in the graph that we have 20-year follow-up from the study. So we have a very long follow-up, 15 years after patients stop the medication. And the interesting thing to note is that we saw a risk reduction both during the 5 years that the patients were on the tamoxifen, as well as a similar risk reduction 15 years after stopping the medication. So we still see a lot of the benefit even after the medicine, and that's why we don't really have data to support people being on medications more than 5 years. Just like the previous trial, the benefit was primarily seen in reducing estrogen receptor positive breast cancer. So the next study I wanted to highlight was the STAR trial. So this was looking at tamoxifen versus raloxifene, another type of anti-estrogen medication for preventing breast cancer. This was quite a large study. It included about 19,000 patients, and they were randomized to either raloxifene, which is also a pill you take once a day, 60 milligrams, or tamoxifen, 20 milligrams, again, for a total of 5 years. The same type of patients were included. However, this was only for postmenopausal patients because raloxifene is only approved and effective in women that are postmenopausal. And what you can see in the graphs is that the tamoxifen was a little bit more effective than the raloxifene in terms of reducing the risk for breast cancer. So compared to, it reduced the risk by about 38% compared to what we see with 50% with the tamoxifen. With the non-invasive breast cancer, so with DCIS, the graphs kind of are more similar. So we don't see as big of a difference between the two. So why would we then choose raloxifene potentially over tamoxifen? So the side effects is a lot of times helps make us make a decision. So I mentioned that uterine cancer can be a risk with tamoxifen as well as blood clots. And so you can see in the left, when it comes to uterine cancer, there is a higher risk with tamoxifen, whereas we don't tend to see as quite high a risk for uterine cancer with raloxifene. And similarly, when it comes to blood clots, you can see that there's also a difference between the two groups. And so oftentimes when we're having discussions with patients about which medication may be more appropriate, we're taking into consideration these differences in side effects as well. Next slide. So the last group of medications that we have approved for prevention are the aromatase inhibitors. And there was 2 trials that looked at 2 different types of aromatase inhibitors. So the first one, the MAP.3 trial, looked at exemestane. Aromatase inhibitors are only approved also in postmenopausal women. So those were the ones that were included in this study. It was about 4,000 women in the study, randomized again to exemestane versus placebo for a total of 5 years. And they saw a reduced relative incidence of breast cancer of about 65% with the exemestane medication. The aromatase inhibitors can increase the risk for osteoporosis and also for some heart disease events. And so it was important that they noted they didn't see any differences in fractures or in cardiovascular events between the two groups. And then similarly, the IBIS-2 trial looked at a second type of an aromatase inhibitor called anastrozole, again, in postmenopausal women only. This looked at about 3,800 patients that were randomized with anastrozole 1 milligram daily versus a placebo for 5 years, and it showed about a 50% relative risk reduction in terms of invasive breast cancer. Again, no difference in the groups between fractures or cardiovascular events. So we have a lot of different medication options that we can offer our patients in terms of risk reduction. So patients always ask me, when you see patients, do they agree to taking medication? So there was a study published a couple of years ago that actually looked at this exact question. So it was a meta-analysis looking at about 26 studies, which included 21,000 patients in terms of these risk-reducing medications. And what they saw was that the uptake was only about 16%. So the vast majority of patients that we see actually don't end up deciding that they want to take these medications. And when they broke it down, they saw there was a higher uptake, not surprisingly, in trials compared to non-trials. So in the real world, we're really only seeing about 8 to 9%, at least in this reported study, of patients that are agreeing to take it. And when you ask patients what their hesitations are, the vast majority are concerned about potential side effects. So that led to this trial, the TAMA-1 study, which basically was looking again at this high-risk population, ADH, LCIS, but this also included DCIS, so the precancerous lesion patients, and it randomized them to a lower dose of tamoxifen, just 5 milligrams compared to 20 milligrams seen in other studies, and just for 3 years of treatment. And then they were looking at similar results, the incidence of invasive breast cancer, as well as quality of life measures. Just quickly looking at the patient characteristics, the majority of patients were postmenopausal. One important thing to note here is that a large percentage of the patients in the study were DCIS, so these higher risk lesions. It was about 70% compared to just 20% ADH and only 10% LCIS. And the vast majority of these patients had lumpectomies as opposed to mastectomies. So a couple of years ago, they presented the 10-year follow-up data. So again, that's 7 years after stopping the 3 years of the medication. And what they saw was about a 42% risk reduction in terms of events of either breast cancer or DCIS in the women who had taken the lower dose of tamoxifen compared to the placebo. And this is just breaking down between the results. So they saw that there was both a risk reduction in the breast that had the ADH, LCIS, or the DCIS, as well as a risk reduction for development in the other breast. So the benefit of the medication was seen in both. Next slide. When it comes to quality of life measures, they did do some surveys of the patients, and the main side effect difference that they saw was 1 more hot flash per day in the tamoxifen group compared to the placebo group, but they didn't see any differences in terms of the severity of the hot flashes, what they call the hot flash score, or vaginal dryness or joint aches and pains. They also didn't see any differences between blood clot risk factors between the two groups or uterine cancer development. There were some increased endometrial polyps in the tamoxifen group, but this was not statistically significant. So there's a couple limitations about this study. It is quite small, so it only included about 500 patients, where compared to our other studies I mentioned had thousands of patients, and 70% of them did have DCIS compared to the other studies, which were largely ADH and LCIS patients. The treatment adherence between both groups was a little bit lower than we generally like to see in studies, so only about 60% adherence in both arms. The study only looked at the lower dose compared to placebo, so we don't have a head-to-head between the full dose that we had used in the past compared to this lower dose. And then while we do have 10-year follow-up, some of the other studies we have include 20-year follow-up, so it'll be helpful to know in the future, further down the road, if we still see this same benefit. So this is my last slide. I just kind of put together a little chart here that includes the three main categories, main medications that we think about, who can kind of take them, how you take it, the different common side effects that we see. And basically this is the way that, we all kind of approach our patients and the conversations that we have when we're trying to figure out what might be the best risk reducing medication for each patient. And with that, I will hand it over to the next speaker.
Thank you, Dr. Simons. Excellent, excellent presentation. Our next speaker is Dr. Danielle Seidman, and she is a breast-focused medical oncologist seeing patients in Mineola at NYU Langone, Long Island. She's a born and bred Long Islander and completed her undergraduate degree at Johns Hopkins in Public Health and History of Medicine, and she earned her MD at Jefferson Sidney Kimmel Medical College in Philadelphia, completing her internal medicine residency at Mount Sinai Beth Israel and her Hem-Onc fellowship at Mount Sinai. Dr. Seidman will be our next and final speaker before we take questions. Thank you. Thank you, Dr. Simons. Excellent, excellent presentation. Our next speaker is Dr. Danielle Seidman, and she is a breast-focused medical oncologist seeing patients in Mineola at NYU Langone, Long Island. She's a born and bred Long Islander and completed her undergraduate degree at Johns Hopkins in Public Health and History of Medicine, and she earned her MD at Jefferson Sidney Kimmel Medical College in Philadelphia, completing her internal medicine residency at Mount Sinai Beth Israel and her Hem-Onc fellowship at Mount Sinai. Dr. Seidman will be our next and final speaker before we take questions. Thank you.
Thank you. Okay, so I'm going to switch gears a little bit because sometimes even despite our best efforts at reducing the risk of breast cancer, patients still, of course, end up diagnosed with breast cancer. And so I'm going to focus on reducing the risk of breast cancer again in breast cancer survivors. So first, let's talk about breast cancer survivorship. So what does survivorship mean? So in the NCI, or National Cancer Institute, gives us a definition. So in cancer, survivorship focuses on the health and well-being of a person with cancer from the time of diagnosis until the end of life. So that includes the physical, mental, emotional, social, and financial effects of the cancer that begin at diagnosis and continue through treatment and beyond. Survivorship experience includes issues related to follow-up care, including regular health and wellness checkups, late effective treatment, cancer recurrence, second cancers, and quality of life. So essentially, from the time that a person is diagnosed with a cancer until for the balance of their life, they are considered a cancer survivor. Now, for the purpose of this talk, we'll consider breast cancer survivors to mean patients who have completed the more active phase of their breast cancer treatment. So these are patients who are now following up, maybe are a year or so, or even a little bit less into their after their diagnosis. So according to the most recent national data, majority of breast cancer diagnosed in this country is localized to the breast only. So 62% of patients diagnosed with breast cancer have breast-only disease. And for these patients, the 5-year survival rate is 99.6%, which is excellent. So we're doing a great job of keeping these patients alive and helping them to survive. That also means a lot of survivors for us to focus on and for us to think about continuing to reduce risk in these patients. So for a little bit of background, one of the ways that we tell the difference between different kinds of breast cancers are through the receptors. So there are 3 possible receptors that are expressed on breast cancer cells. There's the estrogen receptor, which is a hormone receptor, the progesterone receptor, which is also a hormone receptor, and the HER2/neu receptor, which is a protein that's overexpressed in about 20% of breast cancers. Now, if either the estrogen or progesterone receptor is more than 1% positive, then the breast cancer is hormone receptor positive. And about 80% of invasive breast cancers are hormone receptor positive. So a lot of what we focus on in survivorship are these patients with hormone receptor positive disease. Now, the goal of adjuvant systemic therapy, which adjuvant systemic therapy means medications that are given, that are taken, that work throughout the body after the time of surgery. So the goal of these medications is to reduce the risk of a local and a distant recurrence of the breast cancer coming back either in the breast itself or anywhere else in the body. And the goal of this treatment is to eradicate the clinically and radiographically occult micrometastatic disease, so disease that's hiding from us that we can't find with our imaging or with clinical exam, that could in the future become true metastatic disease if left untreated. Now, endocrine therapy is a type of adjuvant systemic therapy that alters the hormone environment in order to prevent estrogen from activating tumor growth. So let's talk a little bit more about endocrine therapy, which I know some of the other speakers have spoken about, and I will as well. So this means medications like tamoxifen, which is an estrogen receptor modulator that can be used in premenopausal or postmenopausal women, aromatase inhibitors, which are medications that can only be used in postmenopausal women and include anastrozole, letrozole, and exemestane, and ovarian suppression, which can be accomplished either surgically or chemically, and this is given in combination with tamoxifen or an aromatase inhibitor as part of some patients' endocrine therapy, patients who would have been premenopausal before starting these medications. And any of these medications are used in certain settings for adjuvant therapy for patients who are breast cancer survivors. Now, the number one best way to reduce the risk of breast cancer in patients with a history of hormone receptor positive breast cancer is to take the recommended course of endocrine therapy. And that's the first most important advice is if your doctor has recommended taking a course of endocrine therapy, then the best thing that you can do to reduce your risk of future breast cancer, whether that's a local recurrence of disease, a metastatic recurrence of disease, or a new primary breast cancer, the best thing that you can do is take the endocrine therapy that has been recommended to you. So the reason for that is taking either tamoxifen, anastrozole, letrozole, or exemestane every day for at least 5 years reduces the risk of the breast cancer returning by up to 50%. It reduces the risk of death from breast cancer, and it reduces the risk of new breast cancers. So not just the breast cancer that one of these patients has already seen and has already made it through the active part of their treatment, but also these patients remain at risk as long as they have not had bilateral mastectomies. They remain at risk for new primary breast cancers. So the endocrine therapy not only treats the breast cancer that has already been diagnosed, but it works as prevention as well for new breast cancers. So if these medications are so clearly beneficial, then why would anyone not complete the recommended course? And that's, of course, because of side effects. And there are risks with taking any medication. And starting one of these medications is, of course, a risk-benefit analysis of making sure that the risks are not too great to outweigh those benefits. And there are more serious risks, but in our everyday practice, the most common side effects that we are encountering with patients who are on endocrine therapy are menopause type side effects. And what I find myself talking about with patients the most commonly is hot flashes, vaginal dryness, and joint aches. So there are things to do for any of these side effects, and that's one of the most important things that I can make sure that patients understand. If you're having side effects, that doesn't mean this is what 5 years is going to look like. There are things to do. There are ways that we can intervene. So fortunately, we have more data all the time of ways that we can help patients combat these side effects and make sure that we do everything in our power to get them through the recommended treatment course. So for hot flashes, there are a few things that have been shown to be very beneficial for patients. So acupuncture is one of them. Oxybutynin, which is a medication that's used typically for overactive bladder, but used in a lower dose, has been shown to improve hot flashes, prevent a lot of hot flashes in many of these patients and who are taking endocrine therapy. Another option is Veozah, which is a newer medication, which is approved for use for hot flash prevention, hot flash treatment in women, whether they are on endocrine therapy for breast cancer or not. And there are even more options and more ways to tweak the endocrine therapy. And our jobs as medical oncologists, one of the things that we do and that we are very happy to do is help modify the treatment course and help our patients who encounter these side effects manage them so that they can tolerate the treatment. Now, vaginal dryness comes up as well, and this is a problem for patients who are on endocrine therapy and are not. But for many patients who have a lot of discomfort, intervening on this issue can help them make it through their treatment course. So for vaginal dryness, coconut oil suppositories or just coconut oil can be helpful, especially for patients who say, I've had enough of medications and I want something more natural. Now, hyaluronic acid has also been shown to be helpful for many of these patients, and that comes in suppositories or in moisturizers as well. And in some situations, a low dose vaginal estrogen may be safe. It's likely safe as long as, used in moderation and as long as it's been discussed in detail with your oncologist. But if the non-hormonal options have not been helpful, then sometimes this is appropriate. Now, joint aches, this definitely comes up a bunch. So acupuncture has also been shown to be helpful for joint aches that come from endocrine therapy. Exercise is one of the best things that you can do. The more that you are moving, the less likely your joints are to ache. So the more active patients can be, I encourage them to do so. And that does tend to help with a lot of these joint aches that come from endocrine therapy. Now, medications can be helpful. One of them is duloxetine or Cymbalta, and a lot of my patients have a ton of success getting their joint aches under control by starting this medication. And there are more interventions as well. And we have fortunately, a lot of different suggestions to help patients make it through and manage these side effects. Now, I mentioned earlier that this treatment course is recommended for at least 5 years. So what does that mean exactly? Well, one size does not fit all. There are some indications for continuing the endocrine therapy beyond the 5 years. So for many patients with localized breast cancer, 5 years of endocrine therapy is sufficient. Now, if patients had lymph nodes involved with breast cancer at the time of diagnosis, we know from many trials that have looked at this exact issue that 10 years may be better than 5. Now, for some of the patients with localized breast cancer, next slide, we do see that there may be a benefit to continuing for a longer course, whether that's 7 years versus 10 years. And that decision can be made based on the risk factors of the breast cancer, which include things like grade, genomic assay results, including an oncotype test or a mammoprint result that may have been done at the time of the initial diagnosis. And there's another test that your doctor may talk to you about, which is called a breast cancer index, which can also help guide who needs a longer course of endocrine therapy. Now, this is an example of what the breast cancer index is. So it's a genomic assay that's done on tumor tissue that was already procured at the time of surgery, and it determines a patient's individual risk for late recurrence in order to help patients and their doctors to decide whether an extended course of endocrine therapy might be beneficial for them. And when we get the result, now this is just, of course, an example. This isn't from a real patient, but it tells us yes or no, and then gives us a breakdown of the percentage benefit. So in some patients, this might be helpful in helping to figure out who might need that extended course, especially if someone's having a tough time with side effects and how hard we should work on controlling those side effects versus a shorter course. Some of these things can help go into that individualized decision for each patient. Now, of course, when patients have made it through their 5 years or 10 years of recommended endocrine therapy, the question comes up is it safe to stop endocrine therapy? If this is the best thing that I can do to prevent breast cancer from returning or for new breast cancers, should I continue it forever? And the short answer is yes, it is absolutely safe to stop endocrine therapy at the end of the recommended adjuvant course. And part of that is because the effects of endocrine therapy actually continue beyond the time that a patient is taking it, something called the carryover effect. So some of the earliest trials that looked at tamoxifen showed that 10 years after stopping the tamoxifen, patients who took it had a 41% reduction in the risk of breast cancer recurrence and 34% reduction in the risk of breast cancer mortality at beyond when they had stopped taking the medication. So this is at 15 years after patients had only been taking the medication for 5 years. So the benefit of endocrine therapy does continue even beyond the time when it's been stopped. Now, fortunately, the side effects do stop once you've stopped the medication. So we get the benefit without the continued side effects. So other than taking the recommended course of endocrine therapy, how else can we reduce the risk of future breast cancer events in women with a history of breast cancer, so breast cancer survivors? So number one, exercise. So we've had many trials that have actually shown that that exercise reduces the risk of breast cancer returning, reduces the risk of breast cancer related death, and reduces the risk of death from any cause. Higher physical activity level is also associated with a lower risk of any new breast cancers. So in patients who have had a history of breast cancer, the benefit of exercise is not just for the breast cancer they've already had, but new breast cancers. Now, what does exercise mean? Next slide, please. So 150 minutes per week of moderate intensity exercise. So 30 minutes of walking 5 days a week will get you there. And it will improve your quality of life. It'll also improve your risk of breast cancer. And there are a ton of benefits, but for breast cancer specific risks, I really can't tell you that how strongly I encourage it. And diet. So no specific diet has been conclusive in regards to breast cancer risk for breast cancer survivors, but there may be reduced risks of recurrence with lower fat intake, more fruits and vegetables. I recommend to my patients a Mediterranean style diet, moderately low fat diet. It helps to reduce the risk of the breast cancer returning, and there are a ton of other benefits as well, and it reduces the risk of new primary breast cancers. And of course, breast imaging. So unless a patient has had bilateral mastectomies, having had breast cancer once doesn't mean you're finished with your breast imaging. Keep going with your regular breast imaging as recommended by your physician. So overall, in summary, how can we reduce the risk in breast cancer survivors? Well, first, take at least 5 years of endocrine therapy if hormone receptor positive. Take up to 10 years if that's been recommended by your doctor. Exercise, 30 minutes of walking 5 days a week. Adhere to a healthy diet, moderately low-fat diet, and continue with your regular breast imaging as long as you have not had bilateral mastectomies. And that's it. Thank you.
Thank you, Dr. Seidman. We have time for a couple of questions, so I will just open this to the panel. One question, which I think Dr. Gemignani may be more for you, but is open to everybody, is how can I tell if I have dense breasts? Is there anything I can do about it? And I think, you know, we hear so much about dense breasts, and then I hear from my patients all the time about how certain insurance companies won't cover additional imaging. So what can you tell our listeners about that?
Yes, so breast density, there's extremes of breast density, which only occurs in about 15% of patients, which means really extremely dense breasts. The majority of women had heterogeneously dense breasts, and what that means, it's a combination of some fatty breast tissue and some dense areas. And so the majority of times it's given as a category on your mammogram, or your mammographer tells you that your breasts are dense, or sometimes on physical exams, your doctor will say so also. But for premenopausal patients, and even for some postmenopausal patients, we do recommend some supplemental imaging with ultrasounds to help with the density and the screening. But there isn't much you could actually do to change the density of your breasts. In some postmenopausal women who are on hormone replacement therapy for long periods of times, they have more dense breasts. And so sometimes using a shorter course of hormone replacement therapy longer, like after menopause, is probably indicated, but there isn't a lot you can do to change the density of your breasts.
Great, thank you. One thing that I would like to bring up to the panel is, we've spoken a lot about risk reduction, and in your discussion with your patients, how do you sort of combine that with the fact that many of these things that we do for risk reduction don't actually have a survival benefit? Does that come up in conversation, and how do you address that? I know that's particularly frustrating for me in terms of trying to convince people, when you talk about the side effects, to go on some of these medications. What do you generally tell your patients?
I would say I generally, I mean, it's a conversation, obviously, always with the patient about the risks and the side effects, their other medical problems. I kind of try to gauge a little bit with the patients how, for lack of a better term, risk averse they are, I would say. So kind of get an idea from them, how willing they are to try a medication. I usually tell them that we have a pretty good idea of how they'll tolerate the medicine in the first couple of months, and that when you stop the medication, the majority of side effects resolve pretty quickly. And so if patients are interested at all in any type of risk reduction, that trying the medication, in my opinion, is a good option for them.
And of course, it depends a little on the diagnosis. I mean, if you have an invasive breast cancer and you're talking about treatment that Dr. Seidman was talking about for reducing the risk of recurrence, that's different than if you're talking about DCIS and reducing the risk of a overall survival, changing overall survival, or another breast cancer. And we'll just point out there are, as Dr. Gemignani was, alluding to and pointed out, there are situations where we do reduce the risk of breast cancer in high-risk patients by surgery.
Excellent, thank you. Another question from one of our listeners: can you discuss the limitations of screening, since breast cancer type biology doesn't necessarily do better when it's detected early?
So I'm going to start off on that one. So we always do better with earlier diagnosis, period. And one of the benefits of screening and using mammography and ultrasound and some of the things that we use is that the earlier you're diagnosed, it doesn't matter so much the biology of the type of cancer, the better you will do. So it's important to kind of understand that screening for breast cancer, and sometimes we start earlier if you have a higher risk, but for the average risk woman starting at 40 every year after that does save lives. And so I do want to say that early detection is part of that intervention. So screening is definitely necessary.
Yeah, I just want to second that. It's really important. There's all kinds of stuff that comes out in the media and in the lay public. And the reason the United States has a very different mortality from breast cancer than Europe, Western Europe, is because we have very clear guidelines about screening, and we try to encourage women to do that because it clearly changes overall survival.
Yes, I agree. And I think that a lot of what people are used to seeing in the media is the recommendations for women at average risk, which is true for a large population, but not for everybody. And I think that's one of the importances of this conference, is to have people understand that they may be at higher risk and actually parse out those who are at higher risk from those who are not. Maybe if we could wrap up just saying a little bit about lifestyle. And I know in my experience, sometimes in terms of risk reduction, sometimes people will say, well, if I don't want to take tamoxifen, et cetera, what can I do to prevent this or to reduce my risk? Are there vitamins, herbs, supplements? What exactly can I do without taking tamoxifen? So if maybe we could go through the panel and just tell our listeners what your answer to that would be.
So I'm going to echo what Dr. Smith brought up about one of the things that we know is alcohol consumption, and making sure that your use of alcohol is limited, especially for women, is a huge intervention that will reduce risk. And the second thing that I would add to that is exercise, because you're sort of modulating a lot of your own endogenous estrogens that way. And so that I think that there's been a lot of data that sort of supports exercise as a prevention strategy, and also for symptoms and other things. And I'll turn over to my panel.
Yeah, and cigarettes. Keep in mind, it's not just lung cancer, it's not just emphysema, but cigarettes, you've got to get away from them. It's probably the best thing you can do if you smoke for your health, bar none.
Agreed. Diet, exercise, avoidance of alcohol. And as far as supplements, it definitely comes up. And I tell my patients that there's nothing that we've seen so far that truly can provide a true benefit. So there's not enough data for me to be able to say that some supplement is able to prevent breast cancer.
Yeah, and
We need that. We need a supplement like that.
We
Tamoxifen.
do. That's
Yeah.
an uphill battle, though, I think.
Yeah, I think I echo the same as everyone. I think patients sometimes are happy to hear that exercise is important. They think like, oh, great, another reason for me to add exercise into my routine. It's helping reduce my breast cancer risk too. So I try to encourage that as much as possible.
Great, thank you. And I think we can end with one more question from our listener. In patients who had DCIS, who elected a double mastectomy, how important is the benefit of tamoxifen for them?
I'll take that.
Mhm.
There's no role for tamoxifen after a bilateral mastectomy. So the purpose of tamoxifen after DCIS is prevention of new breast cancers. And you've already done the best thing to prevent new breast cancers, and if that's what's been recommended for you, is removal of the breast tissue. So there's no role for tamoxifen after bilateral mastectomies with DCIS.
Great. So does anyone have any other last comments, statements that they would like to make? I really thank all of you so much. This was an excellent discussion of risk reduction, things that we can do, what works, what doesn't work. And I think anyone who listened to this really got a tremendous amount of information on how to proceed for their breast health going forward.